Welcome my dear students. We are on a pharmacology multiple choice question session and we shall be doing some of the questions on this session. Let's go to the first question. Combination oral contraceptive agents are least likely to produce. Combination oral contraceptive agents are least likely to produce. Options are weight loss, headaches, thrombotic events, gallstones and elevation of blood pressure. Yes, this is about the combination oral contraceptive agents. When you use the word combination, it means it's going to contain an estrogen and going to contain a progesterone. And you know, oral contraceptive agents produce a number of adverse effects. Let's start from down. Elevation of blood pressure. Yes, elevation of blood pressure. There's sodium retention, edema. This is a progesterogenic effect. Then next one, that's D, is gallstones. It's a common adverse effects of estrogens. Next one, thrombotic events. Yes, there are thromboembolic phenomena. That's an important severe adverse effect of estrogen therapy. Headaches. Headaches are common to both estrogens as well as progesterones. Both are known to produce headaches. And estrogens are likely to produce migraine headaches. And the choice A is weight loss. Think about these drugs. These are steroidal structures. And we said about elevation of blood pressure. We said sodium retention, water retention, edema. So weight gain is one of the most common adverse effects of oral contraceptives. Weight gain, weight loss is least likely. It has to be, if it is anything to do with the weight, it has to be weight gain and not weight loss. Let's go to the answer. Yes, weight loss. And I've written down estrogens produce gallstones, they produce thrombosis, that's thrombotic phenomena, and progesterones and estrogens both together, they can produce fluid retention, they can produce edema, and they can produce weight gain. So always remember, it will be weight gain and not weight loss. Let's go to the next question. Question number 2 on this session. Which is most likely to precipitate hemolysis in glucose 6-phosphate dehydrogenase deficiency patients? These drugs which produce hemolysis bleeding in the patients with glucose 6-phosphate dehydrogenase deficiency are supposed to be the oxidant drugs. And as you know, many antimalarial agents, they can precipitate this hemolysis in G6PD deficiency. Let's go to the options. A, artemisinin. B, chloroquine. C, quinine. D, primaquine. And E, sulfadoxine. So examiner has given you all the 5 options which are antimalarial drugs, and you need to remember the drug called primaquine is maximum susceptible to precipitate hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency. So I take you to the answer, and the answer is primaquine. Let's move on to the next question. Question number 3 on this session. Oral sucrose is not useful to treat hypoglycemia produced by. Oral sucrose is not useful to treat hypoglycemia produced by which of the following drugs? A is glibenclamide, B is pioglitazone, C is acarbose, D is tolbutamide, and E is meglitinides. As you know, the drugs which release insulin act by releasing insulin releasers, they are more likely to produce hypoglycemia. And as the drug is more and more potent, it is going to produce more hypoglycemia. And when there's hypoglycemia, the usual way is to give glucose most of the times by oral route of administration if it's mild. And whatever sugar we are going to eat, normally when you rush for sugar, when you get hypoglycemia, will be normally the table sugar which you use at home. And it is not glucose, it is sucrose. So that's likely to be taken, and many times you can help this hypoglycemia by the sucrose. But there are few agents which are called as the drugs which are going to inhibit the absorption of the complex sugars into simple sugars in the intestinal brush border. And you can see a name here, it's very apt name, is called acarbose. So this is the drug which decreases the absorption of the sugar. So if this drug is given and if you eat sucrose, the sucrose is not going to be absorbed. So the answer is acarbose. Let's have a look at the other drugs. That's glibenclamide. It's a sulfonylurea. Pioglitazone. It is a PPAR group of drugs. Then the next one after acarbose is tolbutamide. So tolbutamide is also a sulfonylurea. And meglitinide is also a sulfonylurea. So all those 4 have got different mechanism of action. And only acarbose has got a special mechanism, and it inhibits the enzyme. Please remember the name of the enzyme, alpha glucosidase. Alpha glucosidase inhibits is helping the conversion of sucrose to glucose or complex sugar to simple sugar, and acarbose is an alpha glucosidase inhibitor. So even if you eat the sugar, this sugar will not get converted into glucose, it's not going to get absorbed. So the simple oral sucrose is not useful to treat hypoglycemia produced by acarbose. There is one more drug in this group, and that's called miglytol. So please remember acarbose and miglytol. If there is hypoglycemia, it has to be oral glucose, only glucose. Sucrose is not going to be helpful. I'm taking you to the next question. Metronidazole is useful to treat. It means the examiner is asking you, what is the condition in which metronidazole is useful? Okay. A. Salmonella typhi infection. B. Malaria. C. Anaerobic bacterial infection. D. Candidiasis. And E. Toxoplasmosis. So let's go one by one. Salmonella typhi infection. There will be Salmonella typhi diarrhea, or there can be typhoid fever. Have you heard metronidazole in typhoid fever? No. Next is malaria. Try to remember the anti-malarial drugs, the classical anti-malarial drugs like chloroquine and the related drugs. In addition, you have artemisinin, artemether, you have sulfadoxine, pyrimethamine, you have tetracyclines, and metronidazole is nowhere in the list of malaria. Next one is anaerobic bacterial infection, and this is to be remembered. Normally, if anyone asks a student what is metronidazole, he says anti-amoebic drug. That's right. But what's the most important use of metronidazole in clinical practice? And that's the anaerobic bacterial infections, especially the post-operative infections, hospital infections, and the deeper tissue infections, gynecological and pelvic and intra-abdominal infections. And for anaerobic bacterial infection, metronidazole is a very useful drug. So that's the important use of metronidazole. What is likely to happen is you just keep on remembering amoebiasis and forget this important use. So that's anaerobic bacterial infection. Next one is candidiasis, and that's a fungal infection. Metronidazole is not antifungal agent. And last one is again Toxoplasma gondii, for which the drug of choice usually is a sulfonamide, and it's not metronidazole. Let's go to the answer. Yes, anaerobic bacterial infection. Next question. Match the correct option for nystatin. Match the correct option for nystatin. What is nystatin? Nystatin is an antifungal agent. Let's go to the options. Antimetabolite, ergosterol synthesis, microtubule assembly, artificial pores in cell membrane, and lanosterol synthesis. Are you getting it? If you did well, you should be able to get it. That's a simple question. It's asking you the mechanism how nystatin acts. Nystatin is a Pauline antibiotic. It's from the same group as that of amphotericin B. And this is why these drugs lead to formation of artificial pores in the fungal cell membrane. That's a very, very classic effect of the Pauline antibiotics. So they'll combine with the ergosterol in the cell membrane, and then they'll form the artificial pores, and there'll be leakage of the substances from the cell membrane. So that's the mechanism of action for nystatin. Let's go to the answer. Yes, artificial pores in cell membranes. For your kind information, I have added the description of rest of the mechanisms. The first drug is antimetabolite, and which one is antimetabolite for your revision? 5-FC, 5-flucytosine. Next one is ergosterol synthesis. This ergosterol synthesis is blocked by the azole antifungals by inhibiting the conversion of lanosterol to ergosterol. Right. Next, microtubule assembly. The drug which inhibits the microtubule assembly is griseofulvin. It's written down. Next, artificial pores in cell membranes. What we discussed just now is Pauline antibiotics. And lastly, lanosterol synthesis. Lanosterol is synthesized from squalene. So the step squalene to lanosterol by the enzyme squalene epoxidase is inhibited by the drug, the last drug mentioned there, that's terbinafine. So we could revise the mechanism of action of many antifungal agents. Let's go to the next question. Citalopram is a. Look at that examiner. The exam is very typical. He wants to know the very basic things. And if you could identify the drug is from which class. And that's why many times I say you should have a good classification notebook. And you should be able to immediately identify the drug is from which particular group. And then the rest of the job is easy. Let's go to the options. Citalopram, atypical antipsychotic, tricyclic antidepressant, newer benzodiazepine, selective serotonin reuptake inhibitor, and anti-seizure drugs. Are you getting the answer for citalopram? Straightway I take you to the answer. It's a selective serotonin reuptake inhibitor. You have to identify the class. That's important. Let's go through some of the other classes which are asked on these particular options. One is atypical antipsychotic. You know, the typical antipsychotics are chlorpromazine, haloperidol group of drugs. Atypical antipsychotics, the list always starts with clozapine, olanzapine. Then you have risperidone, a safe agent, and you have newer agents, aripiprazole, quetiapine, ziprasidone, etc. Right? So that's not citalopram. Next one is tricyclic antidepressants. I'll give you a hint how to remember it. Tricyclic antidepressants are pramines and triptylians. I'll take some names: imipramine, desipramine, pramines. Triptylians, amitriptyline, nortriptyline. These are tricyclic antidepressants. Newer benzodiazepines. Many newer benzodiazepines ending with pam, or if it's a non-benzodiazepine, really speaking, what you sometimes call newer benzodiazepine, are the Z drugs. Zolpidem, zaleplon, zopiclone. So it's not a benzodiazepine. And the last option is anti-seizure drugs. You already know it's phenytoin, carbamazepine, valproate, etc. So I hope you understand. You need to identify the class. Citalopram is a selective serotonin reuptake inhibitors, and there is citalopram and S-citalopram in this particular group. And the SSRIs also have zetins, that's fluoxetine, paroxetine. So once again, to repeat, as far as the antidepressants are concerned, tricyclic antidepressants are pramines and triptylians, and the SSRIs are zetins and prams. So fluoxetine, paroxetine, and citalopram, S-citalopram, and of course there are more drugs. So that's citalopram. Next question: which of the following is combined with piperacillin? I hope you remember we have extended spectrum penicillin. So that's an extended spectrum penicillin, piperacillin. Which of the following is combined with piperacillin? Tazobactam, sulbactam, clavulanic acid, cloxacillin, and carbenicillin. Piperacillin is an extended spectrum penicillin, and it acts against gram-negative infections, especially Pseudomonas. Down you see carbenicillin. Carbenicillin is also an extended spectrum penicillin, inhibits Pseudomonas. Naturally, you are not going to combine these two. What is cloxacillin? Cloxacillin is a penicillinase resistant penicillin. It's less likely we are going to combine it with piperacillin. It's also a penicillin. And now you are left with three options: tazobactam, sulbactam, and clavulanic acid. You know, clavulanic acid can be used by oral route of administration, and the other drug in the combination also has to be a drug which can be used by oral route of administration. So many times amoxicillin clavulanic acid combinations available. But sulbactam and tazobactam, they have to be injected, and naturally they cannot be used in a combination which is to be used by oral route. And if you know, piperacillin cannot be given by oral route of administration, it has to be injected. So you have to have a beta lactamase inhibitor like tazobactam or sulbactam, which has to be injected. And between sulbactam and tazobactam, piperacillin combination is most commonly done with tazobactam. So please remember, piperacillin tazobactam combination. I showed you the answer. That's A, tazobactam. Let's move to the next question. That's question number 8. Choose a drug with weakest anti-inflammatory activity. Choose a drug with weakest anti-inflammatory activity. And the options are piroxicam, acetaminophen, ibuprofen, naproxen, and phenylbutazone. So what is done is, most of the anti-inflammatory drugs have been shown here, and you have to choose a drug which has got weakest anti-inflammatory effect. Simply you can go to each drug and ask yourself, is it used for inflammatory conditions like rheumatoid arthritis, osteoarthritis, etc. Piroxicam, anti-inflammatory? Yes. Acetaminophen. What is acetaminophen? Acetaminophen is nothing but your paracetamol. Do we use paracetamol for rheumatoid arthritis, osteoarthritis? No, we don't use. Most commonly we use paracetamol for fever. We take paracetamol when we have headache. So that's important. Paracetamol cannot produce much anti-inflammatory effect. It is mainly an analgesic and antipyretic. Okay. Ibuprofen, yes, a top candidate to be used for inflammatory conditions. Naproxen, yes, naproxen is an anti-inflammatory agent. Phenylbutazone, yes, phenylbutazone is a very potent anti-inflammatory agent, although it's now outdated. So, if you analyze this way, you come to the answer acetaminophen, that is paracetamol. Please remember, paracetamol does not have anti-inflammatory activity. It's only analgesic and antipyretic. You can use it for symptomatic relief of fever, or you can use it for symptomatic relief of pain, that's headache, body ache, etc. Take you to the answer, that's correct, acetaminophen. And down I have written a note, there is another agent which has got weak anti-inflammatory effect, and that's called ketorolac. So probably the same multiple choice question could just replace ketorolac in place of acetaminophen, and that way also it could be asked to you. Let's go to the next question. Yes. Next question. Which of the following is a protease inhibitor? So again you have to identify a class. Options: zidovudine, efavirenz, atazanavir, diadenosine and abacavir. What are all these? These are all the drugs used for HIV AIDS. These are antiretroviral agents. And the exam is asking which of the following is a protease inhibitor. You know, anti-HIV drugs, one of the major important classes is nucleoside reverse transcriptase inhibitors. And the representative prototype drug is the first one on these options, that's zidovudine. And apart from zidovudine, in this group you have many other drugs like lamivudine, stavudine, diadenosine. I'm taking so many drugs. See option number 4, that's diadenosine. So this zidovudine and diadenosine from same group. They are NRTI, nucleoside reverse transcriptase inhibitors. Next, option B is efavirenz. What is efavirenz? It's a non-nucleoside reverse transcriptase inhibitors. So we are left between two drugs now, atazanavir and abacavir, and that's where the examiner is trying to twist, because both the drugs are ending with VIR. And as it is traditionally taught, all the protease inhibitors, they end with this particular spelling, VIR. For example, you have ritonavir, saquinavir, nelfinavir, indinavir. Are you getting it? These are all protease inhibitors. So the examiner is trying to put you in the puzzle by making you to choose between atazanavir and abacavir, because both of them are ending with VIR. But we are forgetting something. The protease inhibitors don't just end with VIR, they end with NAVIR. That's Navir. So I'll take the names once again, you'll realize. Indinavir, nelfinavir, saquinavir, atazanavir, darunavir. Are you getting it? NAVIR. So they are called Navirs. So please remember, protease inhibitors are Navirs. And the drug with which we are trying to confuse is abacavir. What is abacavir? Abacavir is a nucleoside reverse transcriptase inhibitor. It's an NRTI in the same group as that of zidovudine. So I think the question is solved. The answer is going to be, you can see the answer, atazanavir. That's a protease inhibitor. We go to the last question on this session, and the question is, conversion of testosterone to dihydrotestosterone is inhibited by. Who inhibits the conversion of testosterone to dihydrotestosterone? Options: sildenafil, danazole, tamoxifen, finasteride and flutamide. 5 different names from 5 different groups. They are not from the same group. And when you come to the discussion of the sex hormones, I would advise you again to do the classification well. You should be able to locate this drug is in estrogens, this one is in progestin, and the next one is in androgens. Things is going to be easy. So let's try to analyze what is sildenafil. Sildenafil is a drug which produces vasodilation, and this is used for management of erectile dysfunction, right? So it's no way related. Next one is danazole. Danazole you will come across in the chapter of androgens, and it's called as impeded androgen, and is commonly used for management of endometriosis. Okay. Next one is tamoxifen. As soon as you hear tamoxifen, what comes to your mind? Breast. It's a drug of choice for carcinoma breast, if the carcinoma breast is estrogen response positive. So it's going to block the estrogen receptor in the breast. is going to block the estrogen receptor in the breast. This tamoxifen will be useful when the carcinoma breast is estrogen receptor positive carcinoma breast. And I am reminding you, this is called a selective estrogen receptor modulator because it stimulates some estrogen receptors and blocks the estrogen receptors at some other site. So tamoxifen, SERM, selective estrogen receptor modulator, useful for carcinoma breast. And now the examiner has left us with two drugs. Both of them are ending with IDE and both of them are starting with the spelling F, finasteride and flutamide. Flutamide, as soon as you hear about flutamide, don't think of anything else. It's in the chapter of androgens and it's going to be useful for carcinoma prostate. So out of question, we have got finasterides. Both these drugs are from the androgen chapter. So between finasteride and flutamide, flutamide is useful for carcinoma prostate, whereas finasteride inhibits the conversion of testosterone to dihydrotestosterone. This DHT is going to act with the testosterone receptors. So this testosterone is going to produce some important effects. And what's the use of finasteride? Is useful in benign prostatic hyperplasia. I take you to the answer. The answer is finasteride, and that note is telling you identify the enzyme 5-alpha reductase. Testosterone to DHT, dihydrotestosterone. The enzyme is 5-alpha reductase. Let's remember the enzyme and remember the name. That's finasteride. Finasteride is not useful for carcinoma prostate. It's only useful for benign prostatic hyperplasia, and flutamide is useful for carcinoma prostate. So this was our session for some 10 important questions, multiple choice question on various chapters in pharmacology. We touched many chapters. I hope you enjoyed and keep it up, and let's meet on another session. Thank you.